Hello, my name is Robert Barajas, and today I'm going to be presenting my Grand Round presentation. My patient Jane Doe presented to the clinic with a chief concern for a general cleaning. She is a 47-year-old Hispanic female. Before treatment, a thorough medical and behavioral history was taken for the patient. The patient presented with high cholesterol, high blood pressure, and arthritis, each maintained with medications. The patient is an ASA level 3 due to multiple systemic conditions. The behavioral history: the patient reported grinding her teeth at night due to stress. She has a night guard but rarely uses it. She has a habit of biting her cheek, and she doesn't use tobacco or consumption of alcohol. The lesion was noted during the clinical intraoral exam. It is located on the mandibular left retromolar pad behind tooth number 18. It has a localized unifocal distribution. Upon measuring with the probe, the lesion had a length of 3 millimeters with a width of 2 millimeters and a height of 2 millimeters. It was pink with slight paler color. The lesion had a sessile shape with well-circumscribed margins. It was also noted that it had a darker line running down the middle due to trauma and possibly the night guard she was using. It had a smooth surface texture with soft consistency. This lesion was found only clinically and not radiographically. After gathering sufficient assessments and information from the patient, 3 differential diagnoses were formulated. The first one is an oral irritation fibroma. This is a common benign, scar-like reaction due to persistent long-standing irritation in the mouth. It is most commonly seen in older adults who can occur at any age. Common causes are due to cheek or lip biting, rubbing from a rough tooth, or dentures or other dental processes. The second differential diagnosis is an alveolar ridge keratosis. This is a reactive hyperkeratosis caused by trauma or friction that presents as a poorly demarcated white papule or plaque on the keratinized mucosa of the retromolar pad or alveolar ridge. It is caused by chronic trauma such as impaction of food, chronic movement from an ill-fitting denture on the gingiva or alveolar mucosa, or direct trauma from a hypererupted tooth. The third differential diagnosis is mucoepidermoid carcinoma. These are rare salivary gland-type tumors that comprise mucosecreting cells, squamous cells, and intermediate-type cells. Mucosal squamous cell carcinoma affects mostly women between the 6th and 7th decade of age. These are low-grade tumors that develop as painless, slow-growing swelling over several years, clinically mimicking a pleomorphic adenoma or other benign tumor, and rarely exceed 5 centimeters in size. After full assessment and analysis of the differential diagnoses, the patient is suspected to have an oral irritational fibroma. The patient reported grinding her teeth due to stress at night and having an ill-fitting night guard. As seen on the intraoral picture above, it is close to a porcelain crown restoration, which can be a local factor for the irritational fibroma. This patient never knew about the lesion prior to the visit. After diagnosing the patient with an oral irritational fibroma, a management plan was created. The first intervention is to get her night guard adjusted by a dentist, or get a new one. The second one is to minimize cheek biting habits. Thirdly, follow up an appointment to monitor the lesion's size and see if it grows or gets smaller. Lastly, adjust or get a new crown on tooth number 18, since the porcelain restoration may be the factor to the oral irritation of fibroma. And that wraps up my presentation. Thank you for watching.